We want to welcome you all to Venus Symposium Virtual, or as we call it, VSV. It's the third one that we've done over this series. And as of 7:30, as a matter of fact, there was about 1,300 people signed up and registered for this. So we'll see how many come on, but it's been growing each time. And for those of you who have been here before, you kind of understand the format. For those of you who haven't, the way the format is that our speaker today is Tom Maldonado from NYU, and he's going to give us a talk about the management of the patient with leg swelling. So he'll give the talk. That's kind of like for the first half of this webinar, and then during the talk and after the talk, you all can submit questions, and we're going to have an open forum back and forth. This is very casual. It's not a sit down, you know, I hope nobody's wearing a shirt and a tie and stuff in their home. And we'll answer all the questions. We'll get into some good discussion. You look at the bottom of your screen, you can put in the questions on the Q&A icon, and we'll answer them from there. Our panelists today are Makis Avgarinos from the University of Pittsburgh, Kush Desai from Northwestern University, Tony Gasparis and Nikos Labropoulos. They are the founders and the co-directors of the Venus Symposium. They're from Stony Brook University. And myself, Steve Elias, and I'm from Englewood Health in New Jersey. Our sponsor tonight is Tactile Medical. And Tactile Medical really is a company that really helps to treat patients, the type of patients that Tom is going to talk about today with some of their products as well. So we want to thank them for being the sponsor. And Tom, you are up.
Okay, I'm going to share my screen now. See if I can do this right.
As you're doing that, Tom, just to reiterate to everybody, at the bottom of your screen, there's a Q&A box and there's a chat box. So for any questions, please put them in the Q&A box, not in the chat.
Right.
Thanks.
Okay, so let's get started. First, thank you, Tony, Nico. Thank you to the panelists for having me and for Tactile again. We're going to talk about the management of the patient with leg swelling. Let me see if I can advance the slide here. Okay, there we go. So just one of my disclosures here that I am a principal investigator for a trial that is sponsored by Tactile. So we're going to go over in broad strokes here the differential diagnosis of leg swelling, the pathophysiology of swelling, talk about some definitions and classification schemes, management options, and eventually outcomes of treatment for leg swelling. So why do our legs swell? I think that it's suffice it to say that gravity is not kind to humans. You know, unless you want to visit some of the specialists here locally, there you see some of our co-founders here, Dr. Gasparis and Labropoulos. You can see that they can help fight this this tend to have leg swelling, but eventually gravity wins. Unless, of course, you want to stand on your head, and of course that might delay some of the ill effects of gravity. But you can see, all joking aside, why it is that we do develop leg swelling with time. And it really becomes a simple plumbing problem. We have 132 centimeters from the right atrium to the feet in the average person. And that, in addition to the dynamic pressure of the cardiac pump, contribute to the forces that we'll talk about that lead to fluid accumulation and interstitium. Systemic causes of swelling, just to get that off our chest right away, we have to look at these and rule them out. Of course, we want to look at things like cardiac, hepatic, renal failure, hypoproteinemia, hyperthyroidism, allergies, etc. Drugs. There's some drugs that are very important that can result in swelling. And we want to go through this sort of mental checklist when we see a patient with swelling to rule out these perhaps more dangerous causes of swelling. And then we're going to look at local or regional causes of swelling. And I'm just going to focus, just for time's sake, the top three: chronic venous insufficiency, lymphedema, and lipedema. But there are other causes that can give you local or regional swelling. Traditional teaching, this is from one of our textbooks in vascular surgery, Rutherford's textbook, breaks down swelling into sort of different etiologies. We talk about venous, lymphatic, and systemic as the three major buckets of swelling, if you will. You can see some of the characteristics of each of these, but I say that it's traditional and perhaps a little outdated because there's a lot of overlap and a lot of gray area here. And we'll talk about things like phlebolymphodema and lipolymphedema. And I think that's where you kind of have to understand that these are not entirely accurate, these tables. But we do want to look at the patient who presents and try to understand, once we've ruled out perhaps some of the systemic causes of swelling, we want to appreciate whether the swelling is unilateral or bilateral. And generally speaking, unilateral, bilateral tends to be more of the systemic problems, and sometimes unilateral can be these other etiologies. I think this pathway, which I have to give Tony Gasparis a credit for, it's a nice little flow chart that speaks about swelling and how we approach a diagnosis. Again, this is not acute swelling. This is not something that we're worried about, a bleed or perhaps a DVT, but more chronic edema. Again, we very quickly evaluate for systemic causes, as we mentioned. We're going to manage those appropriately. And then if those are not really the culprit, we are going to go through a good history, physical, and clinical evaluation for some of the other causes of swelling. Sometimes you'll have systemic swelling, in addition to these other causes. So it's not necessarily one or the other. We're going to do some diagnostic imaging. We all understand that venous duplex perhaps is the least invasive, most cost-effective imaging modality we have. We can touch upon later some of the other imaging modalities like MR or CT venogram for the pelvis. But suffice it to say, we're going to start to hone in on the different types of swelling. Well, let's talk about venous swelling first. We know that venous swelling is characterized by the SEEP classification. You can see here a nice schemata showing the different C classes, with edema being C3. What you'll notice is this sort of spectrum that as we advance and progress in our venous disease and venous hypertension, we develop more and more fibrosis. And that's going to become important when we talk about lymphedema and phlebolymphedema. Chronic venous insufficiency, to just focus on that for a minute, is a big problem. We know that this affects more than 5 million people in the US alone. Venous ulcers and eventually cellulitis and infection become a big cost, and the medical economics are really impacted by that particular complication. We know the presentation of venous insufficiency: pain, cramps, varicosities, pigmentation, but it's really the end result, the chronic inflammation that can result with long-standing venous hypertension, that we have to worry about, because that's what results in fibrosis. Venous stasis can destroy the lymphatic channels and develop this phlebolymphedema, or mixed venous lymphatic edema. Pathophysiology, we're not going to spend much time, but we know that obviously incompetent venous valves, inadequate muscle pump, or venous thrombosis or obstruction can all play a part in the development of venous hypertension. I'm going to pause here and just throw out a question. Maybe Tony, you can help me with this. Post-thrombotic syndrome, we're going to go into this, but just to see what we can pull, if we can pull the audience on what we think the answer to this question is. Post-thrombotic syndrome, all are true except it develops as a consequence of long-standing venous hypertension, represents a combination of reflux due to valvular incompetence and venous hypertension due to thrombotic obstruction, occurs in greater than 25% of patients at 5 years, and is best treated with anticoagulation. Okay, I don't know, Tony, how that works, but there you can see our results. And the correct answer was the last, which is that in fact, it is not treated with anticoagulation. It is best, it's not best treated with that, but it's really meant to be treated with really preventative measures. And we'll get into that in a minute. So a little bit about post-thrombotic syndrome. It develops as a consequence of long-standing venous hypertension, usually after a DVT. There's a lot of talk about this now when we talk about the ATTRACT trial and maybe trying to be aggressive about intervening for the acute DVT. We're not going to get into that. But ultimately, the final pathway is reflux due to valvular incompetence, destruction of the valves, perhaps thrombotic occlusion that persists. And then what that means is increased pressures, the capillary beds, which promotes this transudation of fluid, large molecules, resulting in edema and fibrosis. Again, that word keeps popping up. There's a nice representation of venous post-thrombotic syndrome here. You see the staining, the sort of indurated appearance, the swelling, of course. It's an incidence of 28% at 5 years in some of these studies. And you can see here that it's something that increases over time. And it can sort of be insidious because you see someone with a DVT that seems to be doing okay in the couple of months following the DVT. And slowly this process creeps up on them as that fibrosis starts to accumulate. So PTS is a real problem. Let's talk about lipedema for a minute now. That was venous etiology, let's talk about lipedema. Here's another question for our audience. Which of the following is true regarding lipedema? It most frequently is unilateral, overwhelmingly more prevalent in women. The physical finding includes fat deposition in the calf as well as a buffalo hump in the foot. It responds best to diet and exercise. Treatment options include pneumatic compression and liposuction. Okay. So in fact, as you'll see, the correct answer here is not 2, but 5, and we'll go over this in a minute. So it does, in fact, result in subcutaneous fat deposition. The feet and the ankle tend to be spared. This, in very extreme examples, like the picture on the right, is quite obvious. You see this massive deposition of fat, except in the foot and the ankle. This results in sort of columnar, column-like legs. It can affect the upper extremities. The etiology is truly unknown, but there's this hormonal culprit because it is almost exclusively in women. Lipedema is not really something we see all that often in men. It tends to be bilateral. It can be painful and result in easy bruising, and it's not relieved with elevation. The treatment is compression to prevent progression to the lipolymphedema. And this is, again, similar to phlebolymphedema with the venous system, but with people who have lipedema, over time, they can develop lymphatic problems as well. And that's really what we hope to do with compression is forestall or prevent that lymphatic complication. The debulking surgery is something that is, in fact, sometimes very useful. Liposuction or sort of plastic surgeons sometimes will do major debulking of some of this fat. It can be very incapacitating, this disease, and people sometimes can't even walk. And so that is, in fact, an option. It does run the risk of damaging lymphatics, something to keep in mind. So third, but last but not least, we're going to talk about lymphedema here. And much like the others, there are staging systems for lymphedema. You can see here the clinical staging 0, 1, 2, and 3. And without reading all these sort of verbatim, suffice it to say that stage 3 is sort of the classic sort of elephantiasis, the classic poster child for lymphedema. But in fact, this, like venous disease, is a spectrum. And what we really want to pay attention is to the fibrosis. That's where we start to have sort of more irreversible damage to the lymphatics. When we see the early stage 0, stage 1, or even early stage 2, we can intervene and prevent development of fibrosis. And that's where we want to aim our treatment. Classification based on morphology is shown here. You know, lymphatics are really one of the most poorly understood pathophysiology is most poorly understood of the venous, the arterial, the circulation. You know, we produce 8 liters of lymph every day. 4 liters get sort of reabsorbed. The fluid gets reabsorbed at the primary nodal basins, and then 4 liters continues through the thoracic duct, very protein rich. You see that there are different classification systems based on obliteration versus hyperplasia. Most of them are obliteration, as you can see here. We can also classify primary and secondary lymphedema. The primary lymphedema types can be congenital at birth, lymphedema precox in younger ages, and tarda at much later ages. We can also classify secondary lymphedema, those that occur sort of as provoked either by surgery, lymphatic trauma, obesity, or radiation therapy. And this is, again, traditional teaching. I think it's important to point out that what's absent in this traditional teaching is chronic venous insufficiency, phlebolymphedema. This is something that in the last 10 years has had a sort of a renaissance or a rebirth in understanding what this is. But if you look at some of the older textbooks, they don't mention this at all. And that's really, I think, a mistake. Signs and symptoms, there's that sort of elephantiasis, stage 3 lymphedema you see there. There's an expansion in the interstitial space. You see the stemmer sign and the buffalo hump there. Pineoedema, especially early on. Later on, you'll have more induration, fibrosis. Pain is not so common, unlike lipedema. It's very rare. You have aching and heaviness, but not really pain. But perhaps the most dreaded complication of lymphedema is cellulitis, infection. We're not going to get into physiology, how the immune system plays into the lymphatic system, but clearly cellulitis is one of the known complications of patients who have lymphatic damage. So I mentioned phlebolymphedema and lipolymphedema. I think, again, here's where we have to really kind of reteach ourselves the physiology. The Starling equation we're all familiar with. P is the pressure that's driving fluid out of the capillary. and the oncotic and the capillary pressures. We've talked a little bit about the hydrostatic column and the pump, the dynamic pressures. But what was once thought of as simply a reabsorption of fluid at the capillary level of nearly 90% back into the veins, with only a very small amount of fluid entering the lymphatic system, has really been reevaluated and redefined. In fact, we now know that there's a glycocalyx, almost like a slime-like layer that lines the venule and the capillary vein and prevents some of that oncotic force from having effect, and therefore blocking the reabsorption, leaving the lymphatics to play the primary role in moving the fluid back. These little primary valves, as you see here, almost act as a sump, and they allow fluid to enter the lymphatic system and eventually travel up to the nodal basins. So this, of course, it makes sense now when we think of phlebolymphedema. It's the venous hypertension that causes all those changes we see in the C classifications. But you see the near-infrared fluoroscopy image on the right corresponding to the same patient, and we see some lymphatic stasis, the dermal backflow and pooling that we see in these later stages of venous insufficiency. Of course, this is a spectrum of progression, C2 to C6. You see comparable changes as we destroy or damage lymphatics, shown in that the lower panels there. So again, these are really two sides of the same coin, is the way I like to term this, phlebolymphedema. So, question now to pause: should superficial venous reflux be treated in patients with lymphedema? Simple yes or no. You see a patient come to the office, it's perhaps not the big swollen leg that we see in some of those later stages, not a lot of induration or venous stasis, maybe some varicose veins, some pitting edema. Should we treat the superficial venous system if we find it to be incompetent? This is not quite as straightforward, and perhaps some controversy here, and I can touch upon that, but I would argue that yes, the answer is yes. And this paper, I think, out of Japan is something I like to talk about in 2009, because they looked at the venodynamic and lymphodynamic results in patients with venous insufficiency. They tried to really understand, in a patient, 39 patients here who have venous reflux in the superficial system. They did air plethysmography and they did indocyanine green fluorescence lymphography. And this allows us to map the transit time, TT for transit time, of the lymphatic return from the foot to the knee. And you can see that gradual return. And then, of course, we do the venodynamics. We can see the venous volume and the venous filling index in panels A and B. And as we have worse C classification, worse venous hypertension, of course, we have worse venodynamics. Similarly, the transit time shown on the right corresponds to worsening transit time as we have worsening C classification. Well, what about when we treat the saphenous reflux? Now, we didn't do ablation, they didn't do ablations, but they stripped the vein. I say it's controversial because one might argue that you're damaging some lymphatics as you strip this. You might damage them unless you do good tumescence. Perhaps it's a role for sclerotherapy, agents. But suffice it to say that after these veins had been treated, the transit time improves at 6 months, as do the venodynamics. So again, this speaks to the idea of the venous and lymphatic systems being intimately intertwined. You see the derangement of lymphatic flow can be reversed with surgical correction. I think this is good argument for treating superficial veins in patients who we suspect of having lymphedema, especially early lymphedema. Here's another question. What is the most common form of secondary lymphedema? Cancer, phlebolymphedema, we just spent some time talking about that, radiation, total hip replacement, or trauma. I got them out of order here. I'm sorry, and the question is out of order from the other, but
doesn't seem to affect the answer.
that's just a little added curveball for you. Right, so cancer, not surprisingly, many people think cancer is the most common. And of course, if you want to, I probably should have worded the question better, because in developed countries, after all, filariasis, some of the parasitic infestations are truly the most common cause of lymphedema worldwide. But in sort of more developed countries, cancer is oftentimes thought of as the most common. But in fact, I will show you that phlebolymphedema is arguably more common. This paper by Steve Dean, which is in press currently, it's not yet published, but it's in press, a recent experience of his addressing leg swelling from lymphedema in a cancer-affiliated PT department. You see, again, the background that is cancer is commonly reported as leading cause. Well, in this 3-year experience, chronic venous insufficiency, in fact, is more common than cancer when we talk about lymphedema. And primary lymphedema, that classic elephantiasis sort of poster child of lymphedema, is only in 13% of patients. It's not surprising. Most common is phlebolymphodema, and this is what we see in our office. So when someone asks you, do you see lymphedema in your practice? If you're thinking of the first patient with the big elephantiasis, you will say no. But when you pause and you understand that phlebolymphodema is in fact a form of lymphedema, the most common form, we all recognize these patients. And this is what we're talking about when we talk about phlebolymphodema. And the conclusion of that paper, in fact, is that phlebolymphodema, not cancer, is the most common form. Interestingly, BMI is a very strong predictor of developing phlebolymphodema. You can see BMI average was 40. Knee replacement was the most common surgical procedure that exacerbated lymphedema. And very importantly, cellulitis occurred in the majority of these patients, but in a third of the patients, but much more in those who had phlebolymphodema than those who had cancer-related lymphedema. Sort of food for thought here is why that might be. And twice the incidence of cellulitis as we progress to later stages. Also interesting when we talk about trying to prevent progression, we want to get to it before the later stage, before cellulitis starts to take hold.
Hey, Tom.
Yeah.
One of the questions, how do you discuss obesity in these patients with superficial venous insufficiency? Do you give them time to work on weight management before going forward with surgery?
Well, obesity is an interesting conversation. I always find that whenever I talk obesity with these patients, I focus on the medical, the diabetes, the medical complications, comorbidities that sometimes come with obesity. I think when, we have a very strong bariatric surgery program for those who are morbidly obese. I think bariatric surgery does a great deal of good, and we'll see sometimes tremendous improvement in some of their leg swelling after the bariatric surgery. But it is an important conversation. I think it's something we should not shy away from. I've had a couple of, sort of angry patients who come away saying he called me fat and that was all he did. And that's not really the message. The message is that this is one of those risk factors that we can control. There aren't many of them. I mean, smoking's another one, and cholesterol, et cetera. We all know the vascular risk factors, but many, and we won't talk about the genetics of lymphedema, but unfortunately genetics is something we can't control. And sometimes genetics plays a big part in this disease. I do have that conversation about morbid obesity with these patients. I think it's important.
Steve Kush, before any superficial deep venous interventions, what do you tell these patients? How do you manage them?
I mean, it's funny because I have a patient who had had a Adams-DeWeese clip placed following trauma in the early 80s.
Oh, Kush.
Yeah.
For those of you who are not as old as me, can you explain to everybody what a DeWeese clip is and what it does to the vena cava?
It's a staple that compresses the vena cava closed and is, in theory, supposed to occlude it, but I can tell you it's actually not difficult to get a wire across it.
And it's done to prevent pulmonary emboli and stuff.
Correct. Yes, it's the precursor to the filter. And this woman went on to develop left iliac vein thrombosis due to a compression, and she had phlebolymphodema of her leg. And I just had a very upfront conversation with her saying that there's a good chance it's not going to get better, even with iliac vein recanalization and even with opening the DeWeese clip. And I think it's just, it's at that point that the lymphatics are sort of shot, for lack of a better description.
Yeah, and Tony, to what Tom is saying about the the phlebolymphodema is definitely a huge problem. But when you have other confounding things such as morbid obesity, you're ablating a great saphenous vein that has reflux even 3-5 seconds. That's 8 millimeters in diameter. That's not going to make a big impact upon the patient's lymphedema. At that stage, it will make it in early on. Yes, and I agree 100% with Tom on that. So yeah, you have that conversation that their underlying issue really is their obesity, and that's something to first be addressed, and then save the ablation for the future, because you don't want to promise them, as Kush was saying, you don't want to promise them, oh, we're just going to ablate your saphenous and your leg's going to miraculously improve. It's not. I mean, they have.
Steve, you brought up the size of the great saphenous vein being 8 millimeters. How about the vein being 5 or 6 millimeters? Tom, would you treat this?
In a morbidly obese patient, Tom, we're talking about, not in a.
Yeah, I think that I certainly don't want to mislead people in thinking that every saphenous vein has a bullseye on it and should be treated. I think that there are stages of lymphedema and stages of a phlebital lymphedema that I think it's very appropriate to attack the venous insufficiency in the superficial system. The problem with the morbidly obese patient or someone who has, DVT post-thrombotic syndrome, for instance, I think that the saphenous vein probably should not be your first choice. I think that people who have post-thrombotic syndrome and people who have morbid obesity, I think that it's not going to really, it's managing their expectations. They're not going to have big improvement by ablating the saphenous vein. In fact, for PTS, perhaps it might even make them worse. So I think that we don't spend a lot of time talking in the interest of time here about the iliac vein and the May-Thurners and all those, but I think those also need to be kind of really interrogated and make sure that there's nothing in the pelvis. I don't know about the DeWeese clip, maybe it was too far of a lymphedema picture, but I certainly think when you have deep system obstruction proximally, I do try to go out after that if it's in the early stages especially.
No, Tom, we're talking early stages, yes. So all of us feel that. It's the later stages, and there you may not make as much of an impact. Can you talk a little bit, Tom, though? Somebody has basically normal venous function. And we've seen many people, normal venous function with a leg like you're showing us here in the lower right-hand corner. Can you just talk to us about what obesity, morbid obesity does and why it is a cause as well, and what it does that causes the lymphedema in these patients and the cellulitis that a lot of them get?
Yeah, I mean, a lot of it has to do with, quite honestly, hygiene. I think that these people have a big problem with that. I think the pannus, as it kind of is, some of the really, really morbidly obese people have a problem with the pannus sort of, and sort of in the groin area, kind of compressing the groin there. And then there's also a component of lipedema in those morbid obese people as well. So I think it's a lot of different things happening at once in the morbidly obese patient. And when we talk about advanced stages of lymphedema, you can have someone who's morbidly obese but still be in the early stages of lymphedema. So in other words, I don't think it's fair to say, I think the advanced stages of lymphedema, we're talking about fibrosis. That's where I call advanced stages. And so I think that bariatric surgery, I mentioned that early on, because I think that can, especially in someone who hasn't developed fibrosis, can in fact benefit from that and perhaps, stem the development of more advanced stages of lymphedema.
I mean, I think intervention, it depends what you're trying to, in the advanced patient, you're not going to change a patient who's morbidly obese and have them have a normal sized leg. We all know that they're fat. But maybe sometimes I have found intervening on the venous side will decrease their episodes of cellulitis. Not going to change the size of their leg or anything else, but the cellulitis, you may decrease the pressure just enough to have them not have as many episodes of significant cellulitis. And that's sometimes where I find the deep venous, treating that deep venous component to be helpful. But if you do it for a size thing or anything, it's not going to help.
Yeah, I think personally, it's very difficult with these patients to kind of decide what to do. Because it's a multifactorial problem, right? It's their obesity, it's their lymphedema, it's their venous disease, and kind of deciding, and if they have deep disease on top of that, that makes it even more complicated. And trying to figure out what will benefit the patient, and more importantly, what the patient's expectations are going to be after intervention is very difficult. I mean, I kind of, I kind of go on the side of caution and try to be a little bit more on conservative management of these patients with either weight loss, compression, putting them in a pump, just trying to get them to a point where they get some improvement without necessarily going through an intervention that may or may not improve them.
Tony, you have to look a bit differently.
What's the size of the vein that we should be treating? Is it a 10 millimeter vein in somebody that's, a BMI of 45? Is it a 6 millimeter vein?
Tony, I think you have to look differently. Look at the patient. Does the patient's bilateral symmetrical problem regardless of what's going on with the veins? If it is, then mostly is obesity, and whatever you do with the veins, nothing's going to change. Exactly. Is there asymmetrical problem on one side with an ulcer, for example, or skin damage? That leg has priority and is intervened on the venous side regardless of the obesity. You're going to treat the obesity as much as you can on all the patients, but you have to look what is what. The fact is that the majority of people with obesity have symmetrical problems because of this increased central venous pressure and the lack of physical activity. And this has to be addressed not by us other giving advice, but by others, basically.
Right.
But anyway, let's go on.
I have one more question. Is there any type of lymphedema? I mean, there are multiple types of lymphedemas. Any specific type of lymphedema that ablating the vein may actually make things worse? I've heard Tony saying that I avoid doing primary lymphedemas, ablating veins.
Well, I think that I have one patient in particular I can remember, one of the early patients I met, who swears that this was all triggered by a venous ablation procedure. I think that the radiofrequency or laser EVLT, if you don't have good tumescence, there's, I suppose, a possibility of damaging lymphatics there. But I haven't seen that in my practice. I haven't had patients come back after a venous procedure with worse swelling due to lymphedema. Whether it's primary or secondary, again, if it's truly primary lymphedema, I generally haven't recommended ablating their saphenous vein, even if I see reflux. If I really know this patient had lymphedema pre-Cox or something at a very early age and really believe it's primary, I don't think ablating the saphenous vein plays a role.
Okay.
All right,
You
go ahead.
want to move along, Tom?
Okay, so early intervention, having said all that, I think that the name of the game is much like in cancer, we want to diagnose and treat early. I think that's a very, appropriate analogy to treat this as if it was a cancer. We want to avoid intervening when they get to the later stages, the fibrotic stages, because those in fact are not reversible. And I think when we talk about managing expectations in these patients, we all know that there are patients who have been all over the internet on various chat rooms, have been doctor shopping, have been to various clinics and trying to find the panacea for this. And they're very, very frustrated and sometimes even angry. And so I think if we can prevent them from getting to the stage where they've lost hope and where it's an irreversible disease, we do them a great benefit. And that Steve Dean paper showing twice the incidence of cellulitis in the more advanced stages makes a lot of sense to me, is very good data to present to our patients when we want to encourage them to be compliant with interventions at an early stage. So management of lymphedema includes all of the following: attention to skin hygiene, manual lymphatic drainage, advanced pneumatic compression device, limb elevation, or liposuction.
Tom, all of the following except.
Except, sorry.
You did not say except.
I wouldn't have done well on my SAT.
Hold on, sorry.
Excellent. Well, I think we'll go over this, but clearly the management is, again, not a cure. The mainstays of the treatment for lymphedema are skin hygiene for sure, diet, exercise, pressure and trauma avoidance, manual lymphatic drainage, compression, wraps and elevation, and pneumatic compression. I put surgery there. Now, this is not liposuction, but there's clearly an evolving field of lymph node transfer surgery, et cetera. And I would only say that this time it belongs in parentheses, if at all. It's not something that I recommend. I know there are centers of excellence that do this, but I don't think it's something that I'm a big advocate of. I think that in fact, it's very difficult. We can get into a conversation about this, but it's very difficult to follow those patients with surveillance imaging to see whether those transfers have worked. And so anyway, enough about that, but these are the basic mainstays of what we have in our armamentarium to try to maintain and help patients, but not cure them. A little bit about the manual lymphatic drainage shown here. This is more than just a massage. There's a real skill to this, some licensed physical therapists, and I think it has a real important role in management of lymphedema. I think that it can be certainly taught. Patients can do this at home themselves, and there's a real skill set here. You know, it's important reducing the limb. I think it's perhaps less helpful to the patient in maintaining it reduced, because after all, once it's reduced, we want to offer them something that, a little bit more. And we'll talk about pumps.
Yeah, Tom, it's Steve Elias. Can you just talk a little bit about what is the difference between, if you know, I mean, I don't want to put you on the spot, the difference between manual lymphatic drainage, the technique and the pressure applied versus someone going to a massage parlor? It's not, as you said, it's not a massage. Explain how they stimulate the transport of the lymphatics versus a deep tissue massage, so to speak.
Right. So I think that very similar to, and I don't want to misspeak because I've never had this done myself, nor have I ever done it to anyone. But from what I understand, it's very similar to the proximal and then distal drainage. We're trying to sort of relieve the proximal lymphatics, and then the distal, very similar to what a pneumatic compression device would do. And we'll get to that. As far as technique, I hope I'm not misspeaking. Maybe some of the experts in this field who are listening in might want to chime in on the chat. But that's my understanding of how it's done.
No, I was talking about the people. It's not a big pressure. It's not like you're giving deep. You really.
Oh, no, I understand.
You want to
how much pressure?
You want to get the transport in the skin level, and I'm not an expert at these either. My point is,
it's tissue massage. No.
Don't send them to the massage parlor for this.
No.
Who understands how lymphatics move the fluid rather than a massage therapist.
No, I understand. Yeah, no, this is more than that. This is a professional. These are physical therapists, people who really trained in this and know how to do it properly. And so it's not just a massage. It is, in fact, more superficial lymphatics that are being drained. It's not a deep muscular type of massage.
Exactly. I mean, it's really just stretching of the skin and
yes. Tony, can we give some credit to the people that are sending in their comments about what it is? Some of these MLTs, I guess.
I'm a PT. Okay, it is the light pressure that focuses on the skin stretch. You get the anchoring filaments to open in the lymphatic precapillaries. A gentle skin stretch pulls the anchoring filaments, which open the vessels, allowing the flow of lymph.
Yeah, give some credit to the people. Say who this is.
Patricia Cynthia Billings, Patricia Cabral. You got a few people. Donna Orpilla later. Then the Swedish massage involves more than the skin and subcutaneous. They initially start centrally and work out more peripherally.
Right. So I mean, those.
But Steve, there's some request here. Where is it? For you to do a demonstration of this at Venus Symposium live.
For me.
Yes, specifically for Steve Elias at Venus Symposium.
Okay, it depends. We have to find some people that want that. I don't know anything about this. You give me another assignment about how to be a manual lymphatic therapist. Okay.
Not to digress too much, but that idea of tethering filaments being stretched makes a lot of sense. There's no muscle cells in those distal capillaries. And so it makes sense that you'd want to sort of open those up that way. That makes a lot of sense. So I learned something there.
I just wanted to bring all the MLTs in here that know something about this better than we all do. That's all.
Yeah. But the other way to do this is to just put a handcuff on the patient's ankle and chain them to a bed, as you can see in this picture. And that'd be facetious. But in fact, in the early stages, sometimes you'll bring patients in who have cellulitis, and just being in the hospital for 3-4 days bedridden will really dramatically improve their swelling. It makes a lot of sense. When you have the more advanced stage of lymphedema, however, and the fibrosis, that doesn't really do it. And so, but nonetheless, elevation is one of the interventions we can offer.
Tom, I have somebody that actually has raised their hand. So let me see. Let's see.
Oh, you tell people they can raise their hand. Yeah.
Candy Parak, you're open to talk.
Thank you. Appreciate that. I'm a physical therapist and a massage therapist and a certified lymphedema therapist. And what people want to find is a certified lymphedema therapist. They've had extra training beyond the PT. Usually it's physical therapists, occupational therapists, some massage therapists are accepted into the certification programs because they've had enough anatomy to understand the anatomy and physiology that we were all taught before we are taught the treatment protocol, which are all the things you mentioned. But people want to look for a certified lymphedema therapist, a CLT. And you were right. I love the description that the person gave of stretching the filaments so that the initial lymphatic will open to accept the fluid. And what I tell my patients, it is the St. Bernards. The little things can get into the venous system, but the big molecules, mainly the proteins and other debris, have to get into the St. Bernard door, not the cat door.
All right, Candy, where are you located?
I'm in Louisville, Kentucky, sir.
Oh, so you can't teach me how to do this for the next Venus Symposium.
Think of it, there are plenty of folks out there that do it. I bet there's a CLT in your area.
No, there is. I'm joking with you. But
I'd love to. I'll come up wherever. Happy to.
Thank you.
But it's a light pressure. You're correct. It's skin. It's just the skin. It is not Swedish massage, and it is specialized training that needs to happen. Most PT classes, OT classes, or massage therapists, they might get introduced to it, but to become a CLT, you do 300 hours of training,
Right.
and then you take a licensing or a certification test as well.
That was really good. That's interesting. The elevation combined with manual lymphatic drainage, I think, will really be effective in early stages, especially of reducing the limb. And again, reducing and then maintaining are really the dogma here. And you see some pretty impressive pictures. Again, this is out of that Rutherford chapter. I love this picture because I don't think there's anything more dramatic. I imagine it's the same patient. I think so. And you can see here the impact or the effect after 6 months of this wrapping and exercise. But pneumatic compression, I think, is what I want to spend some time talking about, because this is what I think is beneficial, not just to the patient as far as helping their lymphedema, but also what I like to call empowering the patient to take some of the treatment into their own hands. It's a concept that's been around for a long time. It dates back to the early 1800s. There are numerous iterations of this. The single chamber device was first introduced, and right now we have the more advanced pneumatic compression devices that have multiple chambers. The FlexiTouch, which is what I'm going to spend some time talking about. It's, in my opinion, the device that I think I've had the most success with. It's 32 chambers. It inflates and deflates sequentially and kind of mimics this natural lymphatic physiology. Treatments can be 45 minutes per leg. Importantly, there's a truncal piece as well as a leg piece, and I think that becomes important in patients who have lymphedema, that it's more proximal. I think that's another very, very unique part of this system. So again, not all of these are the same. The physiology is also different, not just the number of chambers, but this pump, press and hold action that we see in some of the older models. I think many might make a case can be actually harmful, and induced fibrosis can be very painful to patients. The FlexiTouch is a lighter, more mild pressure, 1 to 3 second intervals. It has that truncal stimulation as well as the more distal. It's a more gentle work and release. And I think it's important just to recognize that not all pumps are the same. And when a patient comes to you to tell you they've tried a pump, make sure you really understand what they've tried. And if it's a basic pump, I think that you have to offer them the more advanced devices. This paper by Maluk and the late Alan Hirsch here, I think, is something I really like to talk about. It's a fairly old paper from 2013, 196 limbs, mostly female patients in this cohort, mostly secondary lymphedema. Follow-up was fairly short, 60 days. But you can see that even in short follow-up, you have a pretty dramatic drop in limb volume, a limb volume reduction of greater than 10% in a third of these patients very quickly. And what I think is also interesting, speaking about BMI and obesity, is that the ones who have a higher BMI tend to benefit the most. Interestingly, the younger patients benefit more than the older. And you can look at this graph a little bit and convince yourself that, but take my word for it, that the younger, heavier patients are the ideal candidates for advanced pneumatic compression with the FlexiTouch. So here I'll pause now. This doesn't have a multiple choice, or maybe Tony, you did put a multiple choice, but I think this is perhaps the most controversial question. When should we intervene for the febrile lymphedema? C1, C3, or C6? You can include C2 and C4, Tony. I don't know if you did that, but.
I'm sorry. This would not pass the question test.
No, that's why I said it's a very controversial question, and I don't think there's necessarily a right answer vis-a-vis the first two. But I will argue that the spirit of this question is that early intervention, you don't have to wait till someone has C5 or C6. In fact, you shouldn't wait until they have C5 or C6, because I think at that point, you know, the fibrosis set in, and you're not going to offer the patient the benefit they deserve at the earliest stages. So I want to just spend a little time now talking about an ongoing trial we're doing at a number of the VAs in the New York area here in New York, New Jersey, using the FlexiTouch device. We just recently presented it at the American Venous Forum. Those of us who went, I know it was sort of a challenging time. That was when the COVID outbreak first hit, a lot of travel restrictions. But this is an ongoing study. This is the interim analysis of 74 of those patients who've completed 1 week follow-up. These are the primary endpoints, mostly quality of life. We have two different quality of life questionnaires, the SF-36 and the lymph questionnaire. Secondary endpoints you see here, change in limb circumference, skin assessment. And then we did look at complications, not just cellulitis episodes, but number of clinic visits, hospital admissions, et cetera, recorded before and after intervention with the LymphFlexiTouch device. The demographics are shown here for these who completed the 52-week follow-up. You see these are, again, from the VA hospital. They're mostly men. 74 of these patients, 60s, in their 67 was their mean age. The BMI is on the high side. These are, by definition, sort of obese patients, a BMI of 32. Most of these were secondary lymphedema, and these really phlebolymphodema patients. As you can see here, 71% with chronic venous insufficiency and only 4% with cancer. And you see the limb volume changes. I think this graph's a little confusing. This one shows it a little bit better. At baseline, the majority of the benefit occurred in the first 12 weeks and then kind of plateaued. And this is interesting to me because despite this early plateau, it's significant improvement in limb girth, but then it plateaus. Despite that, the quality of life questionnaire, this is the SF-36, both the physical and mental component showed an improvement. This one's a trend on the SF-36. The limb quality of life questionnaire showed statistical difference improvement at each time point. And what this means is that even though patients only see an improvement in the limb girth in the first 3 months, they continue to have quality of life improvements. And why might this be? Well, I think this slide answers that question. The cellulitis occurring in the 52-week period prior to FlexiTouch is shown in the left bar, 18% of patients, and it drops to 7%, a pretty dramatic improvement after introducing the FlexiTouch to their treatment. And this is shown here. You see 24% versus 9.5% after. You see the cellulitis episodes also drops from an average of 0.3 per patient to 0.1, both statistically significant. And when we look at the medical encounters, meaning what about these cellulitis episodes, how did it impact their lives? Well, they had a lot more clinic visits before using the FlexiTouch. They had a lot more hospital admissions, the number of hospital admissions. All of these metrics improved after FlexiTouch. And I think that really speaks to why the quality of life continues to improve, even if limb girth doesn't.
Oh, there's a question on this right now. Would FlexiTouch work on stage 3 lymphedema?
I think the answer is yes. I think that the stage 3 is more irreversible as far as the damage to the lymphatics, but the sequela of that damage, meaning the lymph accumulation, the swelling, the cellulitis, those are in fact continue to be positively impacted by FlexiTouch, yes. And I didn't include that slide, but we can break it down by stage of lymphedema, and each stage has an improvement.
Good.
Now, I will say that every time I give a talk on this, someone raises their hand and says, well, isn't this an expensive device? And in the era of responsible, medical economics and cost savings, how do we justify this? And I think this is a valid question. There's a couple of research papers on this, but I think this one speaks specifically to phlebolymphodema. And so I wanted to just show this. This is Stanley Roxon and his group looking at the FlexiTouch device in over 1,000 patients with lymphedema. Again, looking at the cost related to these phlebolymphodema patients. The total cost reduction, the inpatient cost reduction, and the outpatient costs all statistically significantly reduced per year. And again, the reason you're having this cost saving has to do with what I am pointing out in our VA study. You have fewer hospital admissions, clinic visits, cellulitic complications, and all the things that improves their quality of life. Guess what? It also improves the bottom line to the healthcare system because those visits to the hospital, et cetera, cost a lot of money. So again, I'm going to conclude now. We can have some more discussion, but this is a nice review slide of the algorithm, if you will, of how we work up leg swelling, eliminating the systemic problems of leg swelling, and then trying to hone in on lipedema, lymphedema, or venous edema, and then understanding this overlap between the venous and lymphatic systems and the phlebolymphodema concept. Phlebolymphodema is in fact the most common form of secondary lymphedema. Early diagnosis and awareness can help with early intervention and prevention of later complications. goal is reduction than maintenance, not cure. I think you have to set those expectations for patients. You see the list of the treatments here again: skin hygiene, diet, exercise, pressure trauma avoidance, manual lymphatic drainage by a certified lymphedema specialist, compression wraps elevation, pneumatic compression, the advanced devices. Not all pumps are the same. I think the FlexiTouch is really the most sort of the Ferrari of these. Pneumatic compression works. Again, not all of them are the same. 90% experience significant reduction in limb volume. The greater base limb volume and BMI may serve as predictors of limb volume reduction. There's an improvement in quality of life. And I think that it goes beyond just limb reduction. It's because of the decreased number of infection, wound complications, ER visits. And I think that the cost is important to talk about. We spent just a couple slides on this, but there's a decrease in these very costly things like hospital visits, clinic visits, etc. So I think with that, I'll conclude. This is a very nice confocal microscopy of lymphatic valves. We talked about the primary valves at the lymph capillary, but there are more robust valves, lymphatics, and you see a nice image of these. So I grew up with Bob Hope, Steve Jobs, and Johnny Cash. Now there's no Jobs, no Cash, and no hope. Please don't let anything happen to Kevin Bacon.
Okay, good.
Excellent.
Yes, great.
Very nice, very nice. Kush,
So, quickly a question, because on real level this is any role for lymphocytography nowadays?
Yeah, I think that if you talk to Tom Rook or some of these people who work at big lymphatic centers doing a lot of research, I think they do in fact offer patients that. I don't in my own practice. I don't think it's going to change the management of what I'm doing. I don't know the cost associated with that, honestly, but I don't include that in my practice. I think lymphangiograms, some would argue, might even be harmful, but lymphoscintigraphy, radionuclide lymphoscintigraphy is something that I don't do. I think that you all, I think Tony and Nico were talking about doing a study with that, right, in your office now?
Correct, yeah.
Yeah. So I think it's interesting. I think we don't offer it, and I'm not sure truly from a practical standpoint that is going to change your management.
Well, Tom, it may change management only if you're unsure of the diagnosis. So say, in other words, if somebody wants to, if you have a young person or you're going to give them a diagnosis for the rest of their life of, lymphedema, what may seem obvious to almost everybody, but I would say to people, if you're not 100% sure, I agree with you. If it's lymphedema clinically and stuff, it's not going to change your management. But sometimes it is helpful, especially in the younger person, to prove to them we're making a diagnosis of you for the rest of your life. And many of us have seen patients come to us saying, oh, I have lymphedema. And in fact, they don't. They have something else, but they've been told for the last 10 years they have lymphedema. So I would only say I use it when it is questionable in my mind, is this lymphedema?
Tom?
Yeah.
How do you differentiate which patients are going to get lymphatic massage versus getting the FlexiTouch right away?
No, I think they're very much a two-pronged approach. So I think that I generally refer both. I think that the advantage, if you will, I don't know if it's an advantage, but the unique part of the FlexiTouch is that it sort of empowers the patient. They feel a tremendous relief in knowing they can take charge and have some ownership of this disease, which has been frustrating for many years. And sometimes, as I said, they've been doctor shopping, et cetera. I think that I generally refer to the manual lymphatic drainage concomitantly in parallel. So I don't think it's one or the other. I think that's a very important point, is that they really are to be used in concert. Understanding that I think that to have a patient go routinely and regularly for the rest of their life for manual lymphatic drainage, they can be taught at home how to do it. And there may be different opinions on this, but I think that the one of the advantages of the FlexiTouch is that it allows the patient to take ownership and do their treatment at home themselves.
so there's a couple of questions about Medicare patients, and I think basically they're having issues with advanced pumps. And one of the questions, or one of the commenters, said basically they need to use some type of basic pump first and show failure of therapy before, which is usually my experience as well. Kush, do you have a solution for scrotal edema in patients with IVC occlusions?
I mean, that's typically gonadal vein reflux and setting an occlusion because the gonadal veins have nothing to directly empty into, and so they basically drained via paravertebrals and into the azygos system. So recanalization might help. I actually have a patient exactly like this that has a filter-related occlusion that I then percutaneously had to stick the gonadal vein under CT and coil embolize it with the patient prone on the scanner. So, and it worked. And they were looking for fertility. They didn't have a hydrocele. But it's sort of extreme measures.
Yeah, Tony, I'm trying to remember that one of our meetings recently, it may have been at AVLS, somebody showed some very dramatic pictures of patients with scrotal edema and doing basically manual lymphatic drainage and got a huge improvement. I don't know if anyone else remembers. I think it was at AVLS. I was just very impressed by by how much can be done with the manual lymphatic drainage for this problem. I don't think I don't know if the pumps would help for scrotal edema in and of itself.
I think
But
some of the I do think that some of the truncal piece of the FlexiTouch, when isolated scrotal edema, varicocele leading to edema is a different story. But perineal edema in the perineum and I think truncal piece has helped some of my patients.
Yeah, I think it just comes down to, I mean, if there's an obstructive process, that's going to sort of be the other issue that will always be there, even with FlexiTouch or sort of external compression dressings. But if there isn't, then yeah, that's the way definitely to go.
How do patients handle the pain? Many patients complain FlexiTouch can cause pain, or any compression device can cause pain. How do you handle this? You just tell them to be patient or give them painkillers, or they're not compliant for this reason?
Now, I think the basic pump, one of the modes of failure for that is exactly that. I think they're not tolerant of the high hold and high pressure of the basic pump. That's 60 millimeters of mercury in some case. So I think that's one of the reasons why it's not even that it doesn't work. They just don't tolerate it.
One of the questions was somebody that has disappointment in results with endovenous therapy in patients with phlebital lymphedema. What expectations should patients have when they embark on superficial interventions? Kind of somewhat covered a little bit with the obesity patients, but Steve, you want to tackle that one?
yeah, I mean, I think a lot of it depends upon the underlying venous pathology. Is it impressive underlying venous pathology with a lot of varicosities and a huge refluxing saphenous, or is it only a 6 millimeter saphenous with 1.5 seconds of reflux with no branch varicosities? Clearly, that person's not going to benefit as much as the person with significant superficial disease. So that's if they're relatively early in their lymphedema, I think we can tell them they're going to feel a difference if they have significant superficial disease. And certainly, I think it's going to make an impact upon their episodes of cellulitis if they had it. But I would not go chasing a minimally refluxing great or small saphenous that's not all that impressive, because I don't think you're going to make that much impact. I don't know what everybody else thinks.
It makes sense, Steve. I agree with you. It has to be more impressive venous disease to address it.
Yeah.
Many people, they treat what we call saphenous reflux, which is just detected by ultrasound, but these patients don't benefit. In fact, you may harm them if you just treat such insignificant reflux.
All right.
I also work in a wound clinic. Many times I see patients with ulcers and swelling, and we use Uniboots for the treatment of the ulcers. Can we use FlexiTouch on top of the Uniboots with an existing ulcer?
Yeah.
Or it can make it worse?
No, I think you absolutely can. And I think one of the problems with Uniboots and people who have underlying phlebital lymphedema is you'll see the swelling kind of get pushed up to the knee and the thigh. And I think if you use the FlexiTouch in that setting, it can help with that. It's a light pressure. I mean, the pressure your Uniboots is exerting is already much, much higher than any pressure that the light pressure from the FlexiTouch is going to give you. So I think that there's nothing wrong with that. It's not a contraindication then.
Nico, why do some patients complain of pain with use of elastic stockings, but they can tolerate inelastic products?
Well, because one of the reasons for this is because the elastic stocking is continuous pressure all the time, where the inelastic is only working pressure when you actually walk and stuff. It's better tolerated from the people. In fact, it's more effective.
Okay.
Tom, could you just we just go back on the diagnosis and stuff. I mean, all of us have a good idea when it's kind of advanced and kind of obvious. Maybe you can give people some pointers as to what's kind of the subtle signs and or symptoms of lymphedema that patients may complain of, but you may look at the leg and say, gee, doesn't look all that bad to me, but it's the kind of thing you want to intervene sooner rather than later so they don't progress. So I'm just asking really, what are some of the subtle signs?
I think that's a good question. One of the things I like to do, especially in this era of cell phones, and patients will have pictures of what their legs look at different times during the day. And so you'll see a patient in your office and you may be underwhelmed, but they'll break out their phone and show you a picture of what it looks like at the end of a long weekend, maybe with hot weather. And it's remarkable, the difference. So I think a good physical exam is paramount. And the physical exam, interestingly, involves that sort of cell phone picture sometimes. I think the history of distant trauma sometimes for some of these secondary lymphedema, not necessarily febrile lymphedema, but trauma. I mentioned knee surgery, in the orthopedic world. And I think that one of the things I do is, and you touch upon this, Steve, but I don't like to label patients and tell them you have lymphedema. I like to tell them that this is what is in the differential. I think this is the treatment we should offer you and see how you do. And some of these patients, I think that's what they want to hear. They want to have a little hope. And if it's very early, they may not have lymphedema, but you might have treated them with a compression that got better, and it's hard to know. But that's where the diagnostic testing, I think, is important. I think that the lymphoscintigrams, if you have that in your armamentarium, you want to use that, that's great. And it does give patients some peace of mind to have a diagnosis per se. But I think that sometimes there is a role to being sort of empiric in how you treat these patients, understanding that that's really the best treatment for lymphedema. But the cell phone, I think, is important.
There was a question about using a multidisciplinary team. So obviously some of these patients can be very challenging, especially the obese patient or post-thrombotic patient. In the panelists, who uses a multidisciplinary team to address these issues? You know, dietitian, lymphatic therapist, blah, blah, blah. Anybody doesn't?
Yeah, no, we do. I mean, we have a strong bariatric program as well, and we have our therapists in the hospital as well. And if there's wounds, we deal with them in the wound center as well. And the dietitians come in because the patients are, you know, it already says when you fill out your Epic that would you like a dietary consult? So it's like, okay, yeah, we want a dietary consult. But I agree with you. It is a multidisciplinary approach for sure. These are, you really feel sorry for these people because they've been dealing with something for so long. And most people say, oh, just wear stockings. And as Tom said, there's a lot more that can be done.
I think some people take it into different level. When I went to Holland, in Netherlands, right? They have a special psychologist, and it's the first person who sees the patient.
Really?
And the psychologist explains all the aspects of the disease, social and personal. And then they see a special nurse and the doctor, and then multiple other specialists.
Yeah.
Nico, any preference to use of Circade compression system over regular stockings for febrile lymphedema?
Really, first, you have to bring the edema to the minimum that you can, and then with stockings and stuff, you should maintain the size of the limb. And of course, the last slide of Tom, not the funny one, the one before that, addressing all the issues like, you know, preventing episodes of cellulitis, having good hygiene, that's all extremely important. But I think stockings have a role when the limb size is at a decent level, you know. With Velcro, of course, you can get any size of the leg, and may help a lot, can give even on top of an elastic compression or anything. But the CLTs, the MLD, and the FlexiTouch are, I guess, you know, more mainstay treatment to reduce the size first, and then, you know, use additional modalities.
I mean, I think the Circade has real value in patients who can't don a regular stocking. I mean, all of us who've tried to put on a sock can tell you that there can be some challenges. So some of the morbidly obese, you know, I mentioned hygiene. Some of these patients have a problem really reaching down to their legs and cleaning and wearing a sock. And the Circade I find to be very useful in some patients just in the sheer ability to wear compression. I'd rather they wear that and than nothing at all, which you'll give patients stockings and they never wear them. But if you aren't, sometimes that's what they need, something they can put on.
Tom, somebody asked, is the Circade being paid by the insurance or the patient has to pay for it?
I don't know if that's local, geographic or not, but I think that's a challenge. Just like stockings are sometimes not paid by the insurance. I don't think they are, honestly. In my experience, that's a big challenge.
Yeah, so
Unless they have an ulcer.
exactly. That's what I was going to say, Tony. Cercade. So if we see patients with ulcers, seriously, before we heal the ulcer, if we don't think they're going to tolerate stockings, we apply for the Cercade, because if you apply after you've healed their ulcer in the wound center, then the insurance says, no, we can't. It's the silliest thing in the world. So you're right. You got to get them while they have an ulcer. That's usually covered by insurance.
Another
Tom,
interesting question.
one question from an anonymous attendee. Say, all the companies say that their pump works as good as the FlexiTouch. What the FlexiTouch is so special?
Well, I think I touched on this in that one slide about not all pumps are created the same, right? I think that there's a number of reasons. And I'll tell you about one reason that we didn't talk about, but to start, there's the truncal piece. There's this light compression as opposed to the sort of press and hold features that are very high pressure that, in my opinion, can not just impact poor compliance, the patients can't tolerate them, but also can do some damage, I think. And I think the other reason, and this is my bias, and I didn't put this in the talk, but since you asked, I think that there's a real dedication to the tactile sales force to these patients. And when you talk about a multidisciplinary team, I think they're part of that team. They go out to visit the patient. They help size and fit the device to the patient. They plug them into the physical therapist. When I need to know that patient lives in this zip code, where should I send them? They know the physical therapists in their neighborhood. So I think that for all those reasons, but the device itself, I think, in my opinion, is the most studied device, quite honestly. Just like if you were going to study anything, clinical trials, there's very few other devices that are studied as robustly as this one. And I think it has very unique features that make it special. So
It's another question, and I see it all the time. Patients getting diuretics to fix their lymphedema. How do you fight this? Do you stop diuretics? They can actually make things worse over time. How do you handle this?
Well, I think that one slide I had on the flow chart of diagnosis, I may have brushed over it, but there are patients who have systemic problems too. So I think you have to be very careful. If they're starting it because they're trying to fix their own lymphedema, that's different. But there are patients who have been prescribed diuretics because they have a touch of, either CHF or something else. So yeah, I think I always approach diuretics, and I'm not quick to just stop them, because I want to make sure that they're being managed by the appropriate, doctor.
Tom, could you, or anybody, I mean, I could talk about it too, but can you give everybody an idea, even a little more concrete idea about what you really need to document over time or whatever, for the FlexiTouch or anything else to be covered by the insurance? What are some of the key necessary elements in your history and your physical, et cetera, so you don't run into the problem down the road? Oh my God, I didn't say that they have this, and this 3 months ago.
Well, I think you have to document the history, right? A good history document that you've made the proper diagnosis. I tend to be very thorough about my workup and the venous ultrasounds, et cetera. I think compliance with regular compression is important to document. Any kind of complication, especially if they have any kind of element of fibrosis, the more you document, the better, of course. I think we never want to short sell these patients. If you have any venous, advanced venous stasis changes or fibrosis, that can help quite a bit in speaking to the severity of this. I think when you talk about Medicare, we already touched upon this, but unfortunately in that cohort, you have to have documentation of prior use of a basic pump. But most importantly, I think is showing that you've made the proper diagnosis, and the compliance with other conservative measures such as compression socks.
Yeah, and the companies will help you. The FlexiTouch, they'll help you with what's necessary to document as well, which is important for these people.
In fact, we use an electronic medical record, Epic, and they came and assisted us with building a drop-down menu that we simply have a smart phrase that will populate our note, so that we can make sure not to miss. So it's important to work with the company for this. I think they're real champions to the patient. So,
Hey, Kush, Mikey, in patients that you do deep venous interventions, what percentage, and don't tell me 100%, what percentage of patients still have persistent swelling after your intervention?
50%.
Any part, including the ankle?
50%.
If it was including the ankle, probably
Yes.
less than 50% for me, but it's high, 30, 40%.
Right.
It is high. That means we don't select our patients appropriately, or it's just a multifactorial problem.
Well, I mean,
Some improvement.
Also, Mike, no, it comes to
You see improvement.
what he said, Tom, earlier, that, if the people have flammable lymphedema, this is not reversible,
Right.
right? This is the talk like Peter Mortimer gave as a keynote speaker at the Venus Symposium.
But they
Not
feel better.
reversible.
They feel that it may doesn't look better, but they feel better. This is
Yeah.
what I'm seeing many times.
No, Maki, that's right. So when you talk to a patient before you're going to stent them and stuff, what we find is obviously ulcers tend to do much better, and pain does much better than swelling. Swelling is the least that we can improve.
Exactly.
That's important to tell the patients, whether it's due to phlebital lymphedema or it's due to just primary venous disease. So everybody, you need to be a little more careful in setting their expectations for the swelling. But for pain, I agree with you. It's quite effective for pain.
I just wanted, because there was a couple of people asking earlier regarding the webinar. So it's available on the website. It will be available on the website in the next 24 hours or so, vsvirtual.com, as well as all previous webinars and future webinars will be present there. And this is basically our next one that's coming up in a couple of weeks, where Steve is going to be talking about how we make decisions in superficial venous therapies. I mean, we've covered some in this talk and past talks, but this will be geared mostly on decision-making in different types of devices, when to treat what, when to use what device. And that, again, is going to be in 2 weeks, May 12th.
Of course, there was a question to coming, as Tony said earlier, what do you do if the people having iliac vein obstruction, either post-thrombotic or compression? How do you address that in people with lymphedema?
If it's post-thrombotic, I have slightly more optimism that it might help. Certainly not with the swelling component, but if they have a component of venous claudication, or certainly if they have an ulcer and superimposed superficial reflux on top of deep venous obstruction, then I may feel a little bit more compelled or significantly more compelled to offer stenting. In a non-thrombotic compression where the exam looks like lymphedema and they have a non-thrombotic compression, I'm a little bit more hesitant. I really want to exhaust all the conservative measures that you can before you place a permanent prosthetic in. But that's me.
Well, even if it is unilateral?
Yes.
Even if it's unilateral, yeah. Because I mean, look, we're not even at the point that we properly can define which non-thrombotic compressions need to be treated. There's equipoise on that. So given that reality in the treatment of non-thrombotic iliac vein compression, I think you have much less of a clear path forward. But in a post-thrombotic compression, I think we could all agree that the diagnosis is obvious. They have a post-thrombotic compression superimposed on other issues. And so there's a better chance, given that yes, they have swelling, but they also have venous claudication and other things, that treating the obstruction is going to at least improve some of their symptoms. Certainly not all of them, though.
Yeah. Tom, can you talk a little bit about when you get concerned with bilateral lymphedema versus unilateral lymphedema, and when that lymphedema had its onset, meaning days, weeks, months, or years ago? In other words, give the people some idea as to when you may worry a little bit more that there's something else that you have to.
Yeah, I mean, we didn't speak much about primary lymphedema. We focused most on phlebital lymphedema, but certainly part of that medical history is a family history, right? And the genetic component of lymphedema, especially bilateral, is very important. There's a genetic link between the venous and the lymphatic system as well. The COX-E2 and the VEGF receptor 3 mutations have been linked to the venous as well as the lymphatic. And some of those have to do with Milroy's disease and the more early forms of lymphedema, which can be bilateral. So I think bilaterality and family history and how long they've had it all sometimes go hand in hand. So it's part of that history taking is very important to talk about the family history.
No, but I'm also talking about, what about the unilateral lymphedema that the patient said, gee, it seemed to have started about 6 months ago or something like that? Are you going to do any other workup?
Sure. I mean, I'll be honest, to me, we didn't talk much about central venous imaging and pelvic imaging, but one of the things that I'm most proud of is picking up cancers. I mean, when you have a young patient who develops 6 months of leg swelling, for no apparent reason, unilateral, I'm very worried about a mass effect in the pelvis. And whether that's a big fibroid, hopefully that's all it is, or whether it's a more malignant process, I have a series of patients who I've diagnosed a pelvic tumor that has resulted in this leg swelling. So that's probably, for me, the most important reason to do pelvic imaging in a young patient who has a recent history of unilateral swelling.
No, that's exactly why I was asking the question, to make that point to everybody.
Now, I will say that as far as assessing May Thurner's, I think pelvic imaging with CT or MR venogram can be kind of, I find a little bit hard. I think IVUS, if you're really concerned about it, I put a catheter and do a good intravenous ultrasound. I think CT and MR venogram, for the purposes of evaluating May Thurner's, is a little bit less than satisfying, in my opinion.
I was going more towards the non-venous pelvic pathology and a unilateral, that people should always keep that in mind. Don't just say, oh, it's just unilateral lymphedema. Then they, as you just said, the proximal pelvic cause of tumor or cancer or something like that.
Right, and people who have breast cancer, who have some distant history of cancer, I worry about, mets to the pelvis, or we didn't talk about retroperitoneal fibrosis, but that's another one that you want to take a good look at. Surgery, any kind of surgical procedure that can maybe have caused some lymphatic problem. But yeah, I think that pelvic imaging is something that is underutilized.
Nico, any role for vascular in these patients?
So, Tony, for the venotonic drugs, the people having some venous component like fibrotic lymphedema, I guess will help them like it will help people having venous disease. But per se for lymphedema, nobody knows. There is no literature on helping lymphedema with venotonic drugs that we know of yet.
Mikey, how about patients with mixed arterial and venous ulcers? How do you manage these patients?
Well, it all depends about the findings of the arterial studies. If I have an ABI of less than 0.5 or toe pressures less than 50 millimeters of mercury, I would avoid placing compression before I fix the arterial problem. So arterial problem goes first, provided that the pressures are really low. Otherwise, and if the patient doesn't have any arterial ulcer, I wouldn't buy treating if the ABI is more than 0.5.
And I certainly wouldn't ablate the saphenous vein if I'm worried about needing a bypass.
No.
How about a patient who has a venous ulcer or has an ulcer and undergoes a superficial ablation but has no deep vein issues? Do you recommend lifelong compression, or what else do you do? So superficial insufficiency, has an ulcer, you treat the superficial disease, and they have nothing in the deep system.
Perforators are okay.
I'm assuming.
I think that.
What's your algorithm as far as a patient with an ulcer? Let's just start with that. Forget what the presentation is. The venous ulcer has saphenous reflux. You treat the saphenous, the ulcer doesn't heal.
Yeah, I would ablate the perforators as well if it's in that, if it's contributing. And I think that if they've had recurrent ulcerations and you've already treated their superficial, I think that I think chronic maintenance compression is what I recommend, assuming you've worked up again some of the central imaging, some things we talked about. And I do think that pneumatic compression in those patients, again, because again, this is fleeble lymphedema, right? So even though you don't see it, they've been wearing Uniboots, they do have lymphatic damage. So I think those patients benefit not just from compression socks or Circade, but from pneumatic compression.
And are you happy with just axial imaging or ultrasound for the evaluation of their obstruction, or do you do a diagnostic venogram?
I might do a venogram. As I said, I'm very liberal with intravenous ultrasound.
Yeah.
And when would you consider doing a biopsy? When all your findings are negative, would you consider doing a biopsy of the ulcer? When you're against the wall?
That's a great point. I've had a melanoma that, was late in diagnosing. I didn't meet him until it was already diagnosed, but I remember he had this history in the chart of venous ulceration, and it was in fact a melanoma. So you always have to have those things in the back of your mind, I guess. I don't know when you would biopsy, but.
No,
But the dermatologist answer is yes.
Yes.
The paper we did in 799 ulcers from 10 different centers, 2% of what it looked like as a venous ulcer, it was not.
No, Nikos, but the point is also that if you've been treating the patient for 6 months to a year and they're making no progress,
Right.
The thing is, that's when you biopsy. You don't.
Absolutely.
If initially it doesn't look quite venous, you may biopsy it, or you may send to a dermatologist. It's some other strange thing. But if you've been treating it, it's typically venous, and it hasn't healed, it has maybe has undergone some transformation into a, you know, a squamous cancer or whatever. That's, you biopsy it 6 months to a year after you've been treating it and no improvement.
Tom, one last thing we have not touched is briefly, what's the role of lymphatic surgery and when do you decide to send a patient for this?
Yeah, I mean, I mentioned in one slide in parentheses, you probably saw, we
Yes.
have a couple of people in our sort of in Manhattan who favor this. And I suppose like anything, there's probably a role for it. You know, maybe in upper extremity more than lower extremity, I would say is what I've seen. Some of these, you know, mastectomy patients, people, but I'm always worried when I review a lot of papers, and I'm an editor of a journal, and I see a lot of these papers, a lot come from Japan and some of these centers where they do a high volume of these microanastomoses. And I always have a hard time understanding how they follow them. So you can do it technically and you may have some subjective improvement, but the patency of these venal lymphatic anastomoses are always, you know, dubious to me. So I don't have, I'm not a big proponent of this. Some of my colleagues and good friends who are plastic surgeons and very renowned do them quite a bit, but I don't refer generally for that.
And when do you ask for a CAT scan to evaluate for obstruction, but also to rule out a mass? Somebody asks. Do you ever use a CT venogram?
Well, no, we talked about that just now. I think, you know, I think that in especially a younger patient who's had sort of recent unexpected swelling for no other reason, I think it's very appropriate to get central imaging with a CAT scan usually, a CT venogram ideally, so we can look at the vein. But it's not, you know, in someone who's had a 10-year history of leg swelling, I'm not sure it has the same urgency to it. But certainly in the patient that Steve brought up, the patient who has a recent leg swelling unexplained, I'm very quick to look at that.
Yeah.
All right, so I think we can probably wrap up here. We got 3 minutes before locking in an hour and a half in this thing.
Okay, Tom, thanks for the great talk. This is an area that many people think they're comfortable with it, and then once they get into the murky waters, they realize how uncomfortable they should be, and the need for education in this. And so thank you very much for that. It was a great talk and a great discussion. As Tony mentioned before, we're going to be having the decision-making talk from Steve Elias in a couple of weeks on decision-making in superficial vein therapies. And it's really going to cover the whole gamut of not only devices, but patient selection and follow-up. And so I urge you all to join us in 2 weeks. I want to thank on behalf of my panelists and Tony and Nikos, Tactile Medical, for supporting this. It's very important, and their work is critical in taking care of these very challenging and difficult patients. And we thank them for their support in this talk. And to all of our attendees and to the panelists, please stay safe. It's an extraordinarily challenging time. It's good to see that the people here have remained healthy, and we maintain our interest in venous and lymphatic disease, and hopefully we can all see each other in person sometime soon. Thank you.
Good night, everybody.
Good night.
Good night, everyone.
Good night.